So what do we know about SARS-CoV-2 immunity? Well, it actually turns out we don't know a whole lot about it. And our knowledge is constantly evolving. And this is from Nature Review Immunology. It generally follows a standard response. We get the SARS-CoV-2 infection. It creates an innate immune response to the virus. Dendritic cells or phagocytes capture the antigens, and then that triggers our adaptive immunity response and all of the cells I was discussing, which then creates immunologic memory. And if you can see on the graph on the right, how the levels of the virus correlate to the immune response. So you initially have a spike in the virus and the antigen, followed by increase in our antibodies and our T cells and B cells. But you notice they do decline over time. And this is what's been the point of discussion. How important is this decline in these cells, in our immune response over time? And what does that mean with respect to immunity? So just because your antibodies decline, it doesn't mean you're losing immunity. This is the expected response. And when scientists put it, if our antibody didn't decline following infection, we still have big nodes in our neck forever. That is an expected response. And in exchange for losing the antibodies, we develop these memory cells. So it's important to see, do we actually develop immunologic memory? And as well, we can develop cell-mediated immunity. So you might not have antibodies, but you may have these T cells around which have the ability to fight off the pathogens. And it's not just the amount of antibodies we have, it's the quality of the antibody. The antibodies that are directed at the receptor binding domain of the spike protein are better than more non-specific antibodies. Something that's being explored is the role of cross-reactive antibodies. If you've been exposed to other cold viruses in the past, what does that mean for your ability to deal with SARS-CoV-2? And then there's this complicated issue of antibody-induced disease enhancement. And there's a model with dengue fever and with attempts at an RSV vaccine where previous exposure to the pathogen and the creation of antibodies could actually result in worse infection the second time around. And that has been a major concern in vaccine development for SARS-CoV-2. So what do we know so far? It's a novel pathogen. We're learning every day. And there have been some anecdotal data on reinfection, though we don't really have a good sense on if reinfection is possible. It is possible. Some people fight this infection off so quickly and efficiently that they don't actually get to that next stage of the adaptive immunity and the memory cells. And so that makes them susceptible to a subsequent infection. We know from other cold viruses that you can have immunity lasting for several months. And from SARS, it actually was up to 6 years. So we don't know where SARS-CoV-2 falls in that spectrum. Canadian Blood Services just conducted seroprevalence studies on the donors, and that is a very specific population. And it found antibodies in about 1% of Canadians, so not a lot at present. So what does all this mean for immunity certificates? At a population level, they're not likely to be useful at this time. There's not enough humoral immunity at a population level to make this efficient. And I think what we're increasingly realizing is that a lot of the immunity may actually be cell-mediated, and we have no easy measure of that. So if it was antibody-mediated, and we can do an easy test for that, but for cell-mediated immunity, that's much harder to easily test for. So work is underway looking for this. But there may be special circumstances, and this could include the concept of shield immunity amongst high-risk population. And that's where we can intersperse individuals with immunity to immunologically distance people who can't be socially distanced. And this is in crowded workplaces. So like migrant workers, we've seen the problems that we've arisen there, frontline workers, meatpacking plants. There could be a role in these special circumstances to test for immunity and then use this to reduce the likelihood of transmission in these settings. Just something that's throughout there, people who are traveling regularly between provinces, there could be a role for immunologic testing for that to avoid having to do the 2-week quarantine every time. But again, these are very specific circumstances, and we still need to do more learning on the science for this. But I would argue if the science does support this, it might actually not be ethical not to introduce measures like this for populations that we know are getting where outbreaks are occurring. So I'm just going to conclude it with a few words about a vaccine, which is our great hope to get out of all of this. So vaccines are ways of training our immune system to battle invaders. We expose our body to a little bit of the invader, and then it develops that memory, immunologic memory, which allows for the rapid response subsequently. So this is an unprecedented event in human history, the rapidity at which we're developing this vaccine. It's a 15-year process. Normally, we've compressed it to just over a year. There are 3 vaccines that have been approved for limited release. I think there are 2 in China and 1 in Russia, though they haven't gone through the full testing. There are 9 that are in the phase 3 testing, which is our randomized clinical trial. And those will be coming out at various periods, the results of those studies in the next 6 months. But there are a lot of challenges in these vaccine studies that are going to affect our ability to interpret the results. So how do we measure the effectiveness? Well, normally we would look at the impact on disease, but because of a lot of the measures we're taking, we've actually kept the prevalence of the disease quite low. So it may be hard to tell if the vaccines are working in reducing the cases of COVID-19. So a surrogate measure could be the creation of antibodies. Those that have been randomized to the vaccine developing more antibodies to the virus. But we've already discussed there's still uncertainty if the antibody is the main measure of immunity or if there is cell-mediated immunity and other measures of immunity that might be more useful. And I think it's important to be aware that the possibility of adverse events, and again, this is a very compressed vaccine development cycle, and that does increase uncertainty. And we do have previous models for adverse events with pandemic vaccine. In 1976, for the swine flu pandemic, the vaccine that was released early to the US military had a 1 in 100,000 incidence of Guillain-Barré syndrome, which is an autoimmune disease. And even with the H1N1 vaccine in Europe, there was an association with narcolepsy in children. And they think that was an autoimmune process, perhaps related to the adjuvant that was being used in Europe. So before discussing the role of mandatory vaccination, I just wanted to briefly discuss vaccine epidemiology. So the formula for calculating what the level needed for herd immunity is, and herd immunity is the level of individuals with immunity that can then prevent the transmission of the virus from person to person, is 1 minus 1 over the reproductive number. The reproductive number is the number of individuals who are infected for every individual who's infected. So if it's 2, then every individual who's infected will infect 2 other individuals. For the vaccine threshold to achieve herd immunity, the formula is 1 minus 1 over the R naught, the herd immunity, divided by the vaccine effectiveness. So if the vaccine effectiveness is 60% and the estimated reproductive number is 2.2, which were the early estimates for COVID-19, then we see that we need to vaccinate 91% of the population to develop herd immunity. If the vaccine effectiveness is 90%, then 61% need to be vaccinated. So we can see that this vaccine effectiveness is really going to be important in determining what policy we institute. So it's actually kind of paradoxical. So you could argue, well, the vaccine doesn't work so well, we shouldn't be enforcing vaccination. In fact, if the vaccine is closer to 60% effective, that's actually where you might need more mandatory vaccination policies to get up to that 90% coverage that we may need to prevent sustained person-to-person transmission. But if we have a highly effective vaccine, then we could maybe go with more of a voluntary strategy if our goal is to achieve herd immunity. Right now, I think the expectations are we'll probably be close to a 60% effective vaccine, similar to the flu vaccine. Although the good news is that the spike protein does not appear to be mutating, so it is possible we may have more effectiveness. And a few other considerations. These are specific trials we're doing in specific populations. We need to know how the vaccine is going to work in older population. We know with the flu vaccine, we do need high dose versions. The vaccines will not be tested in younger populations, in school-age children. You often need dose reduction studies for those. We need a lot of other mechanisms in place before we go to more coercive policy. We need to be able to track vaccinations, which are immunization registries. We need to have very good post-market vaccine safety surveillance. So this is part of our reciprocal responsibility when we expect the population to agree to an otherwise coercive policy. And a point I continually make is we're the only G7 country without a national vaccine injury compensation program. And manufacturers are requiring indemnification for this vaccine, and they will be in the driver's seat. So I believe Canada is going to need a vaccine injury compensation program. Even countries like Nepal have one. I think 26 countries total in the world do, and I think it's about time we do have one, and just to know Quebec does have a program. So what do I expect to see? There's always going to be uncertainty. We're never going to have a certain answer. And any solution, whether we adopt a mandatory vaccination policy or not, will result in infringement of rights and freedoms. So for example, if you don't bring in a mandatory policy, then people who are being looked after by healthcare workers are being exposed to risk, perhaps unnecessarily. And we will need to balance risks and benefits in whatever approach we take. But this is what I think we will be seeing. There'll be the potential for vaccine requirement and documentation for frontline workers, and they will likely be first in line to get the vaccine. Other employers may seek to bring in requirements, and they might do it because they may not be able to maintain their business being fully reopened, or also be at risk of shutdown if individuals are not vaccinated and outbreaks occur. So we may have vaccinate or mask or vaccinate or stay home policies. And I'll leave it to the lawyers and ethicists to determine whether these will be allowable. There will be no policy initially, and perhaps even a vaccine for children. So we don't need to worry about that difficult issue. Actually, the problem may be we don't have enough vaccine for everyone. We're going to need to make, it's probably going to be a 2-dose vaccine, so we'll need to have 15 billion doses of this vaccine. So the issue may not be, you must get vaccinated. The issue may be, how can I get a vaccine? And I do believe very strongly that we need a vaccine injury compensation program. I'm just going to finish there. If you want to learn more about some of the work we're doing, Can Immunize is our immunization app that we have, it's pan-Canadian, that allows individuals to track their vaccination, and we are making plans to include a potential COVID vaccine there. Immunity Warriors is a comic book which we've developed to teach children about vaccines. And you should follow us on Twitter at Can Immunize. And this is the front page of the comic book that we've developed. So thank you very much.
Thank you, Dr. Wilson. Over to Professor Ravitsky.
Thank you for this wonderful introduction. I learned a lot. My comments on ethics and governance are following precisely in the footsteps of your first distinction, which is between immunity that is naturally acquired following infection and vaccine. So I'll say a few words on each of these scenarios. And this is a critically important distinction from a public health perspective, because if you think about it, yes, we can reach herd immunity by enough people in the population being infected, but we're strongly discouraging people from becoming intentionally infected for 2 reasons. And Dr. Wilson, correct me on the science if you need to. The first is that we cannot predict the severity of the symptoms or the disease in individuals, and therefore for anyone to go and get infected intentionally is pure dangerous. And second of all, we're at the stage that we want to reduce the rate of infection in the population, not increase it. And so the idea of reaching immunity through individuals intentionally going and infecting themselves from a public health perspective has been strongly discouraged and arguably is unethical. Whereas when we think about vaccine, once it's safe and effective, we will want to encourage this practice. So these are very different scenarios from a public health perspective and an ethical perspective. So I want to say a few words about the issues that emerge by each. So regarding sort of natural immunity following infection, as Dr. Wilson noted, the idea of immunity passports has been circulating now for several months, and A lot of bioethics debate has been taking place, many publications. First of all, what would be the benefits? Of course, allowing those who cannot infect others to move around more freely, go back to work, travel, etc. So many benefits for those who are now safely socializing. But the first distinction here from an ethics perspective, I think, is exactly the one Dr. Wilson noted before, between special populations that don't have a choice but to be in close proximity to either sick people or people, and the rest of us who do have a choice, for whom there could be other alternatives that are ethically more justifiable. So I agree with you, Dr. Wilson, regarding the special populations. If we get to reliable, effective immunity passports, they could be ethically justified for those particular populations. But I want to say a few words about the general debate that occurred in bioethics regarding the use of immunity passports for the general population as a way of reopening society. And the questions have been, first of all, empirical. Will immunity last? And I think your bottom line was, we're going to have to live with uncertainty. Did I understand you correctly?
Yeah, that's correct.
Relying on those immunity passports from a scientific perspective, this notion was challenged. And second of all was the empirical concern that people will want to have the benefits associated with the freedom to shop, travel, work, visit their elderly parents, etc., to the point that it will incentivize them to get intentionally infected so that they will acquire the immunity. And that was, again, is dangerous at an individual level and dangerous at a public health level. So these were empirical reasons to object to the idea of immunity passports. But then there were also normative reasons. And they were mostly about equity. So the first idea was that by instituting immunity passports as the primary measure or mechanism for reopening society, we are creating or exacerbating, again, inequality. We're creating two sort of classes. Those citizens who carry these passports and have access to all these benefits, and those who remain very limited in what they're allowed to do. And beyond this initial inequalities, there's the fact that we are, as we all know by now, we're not equally impacted by this pandemic. And so if you don't have an immunity passport, and you're privileged, like us professors, we can work from home, we can do this virtually. If you're rich and you have a spacious home versus less privileged, the impact of not getting access to such an immunity passport are very different between different segments of society. And so there was a serious concern about the impact that such immunity passports can have on overall equality, and the discrimination that this could create, and the inequity that this could exacerbate. So for example, I've published a couple of papers with Professor Daniel Weinstock, a political philosopher, saying basically the following thing. Look, when we choose public health measures, we always have to seek the least infringement of other values that matter to us. And in this case, the value of equality. So if there are effective ways of reopening society that do not exacerbate inequality, we should prioritize those. Very simply, masks, social distancing, redesigning our urban environments to allow social distancing. So I'm thinking about Montreal and how, for example, in some major streets, half of the street is now closed up for traffic to allow more pedestrian area, allowing the use of parks for more purposes. So let's think about designing our space and our time in a way that promotes and supports appropriate social distancing. And let's think about public education about masks and maybe mandating masks as ways that impact everybody equally, rather than immunity passports that just creates this entrenched inequality. So these are my ethical comments about immunity passports. And now I'm going to switch gears and talk about vaccination. So when I look at a high level at the bioethical literature that emerged on what happens once we have, on the way to a vaccine and what happens once we have it, I think we should highlight three main ethical issues. The first one, obviously, safety versus speed. So a global pandemic, an emergency, our economy is suffering, people are suffering. The pressure to get to the safe vaccine is immense. First of all, just in terms of reducing human suffering, but also the economic incentives, especially in certain countries, and the pressure on pharmaceutical companies to move forward very fast. All this creates incentives and maybe legitimizes shortcuts. So how far are we willing to go because of the circumstances in terms of smaller trials, cutting corners, faster approvals? How much attention are we going to pay to reports of adverse events, just like we would in any other trials, or are there sort of attenuating mitigating circumstances here? So the whole debate between the safety of the vaccine that we're producing and the speed at which we want as a society to get there, this has been fraught with ethical problems. Behind this is the second issue of politicizing vaccine approval. Now, this has been extremely present in the US, where we're 2 months away from an election, and the desire to deliver a vaccine before the election to make certain people look good. But of course, if people start thinking that decisions about vaccine approval will be made based on political or economic considerations and not based on safety and efficacy, we lose public trust. When we lose public trust, we reduce the rate of vaccination, and we make mandatory vaccination very difficult to implement, no matter how we frame mandatory. So the issue of public trust is critically important for both of these ethical challenges, the safety versus speed challenge and the potential politicization of the approval of the first vaccines. Now let's go with a scenario in which, an ideal world, we reach the target of a safe and effective vaccine, and we have retained public trust. And now the question is around priorities and distribution. Here again, we have two levels of the ethics debate. National distribution, who gets vaccines first within borders, and there the talk is about older populations, healthcare workers, things that make perfect sense. But another layer of the discussion has been the global one. First of all, should the vaccine allocation be completely determined on a national level, which means each government just fights other countries to get their hands on most vaccines for their populations because their ethical obligation is towards their own populations, their own society? Or is there arguably a global justice element here, where after you've supplied to your local to your local society, to your citizens, enough vaccines to reach a certain threshold, you also have to meet your international obligations and allow the rest of the vaccines to go to societies that could benefit from them more than you could. So a few models have been suggested for this global justice perspective. One was just allocate numbers proportional to the size of the population. That's very simplistic, because maybe you have a big population, but you're very developed countries that used public health measures in a wise way, and you got infection rate under control. And then there's another country that's smaller than you, but needs this much more for public health reasons. So that was criticized as oversimplistic. Another model was, let's look at the composition of the population in various countries and give the vaccine to populations who have, to countries that have more older populations or a greater number of healthcare workers. But here again, that does not necessarily mean increasing effectiveness. And so about a week ago, this paper was published in Science. I'm showing it to you. It's titled An Ethical Framework for Global Vaccine Allocation and it promotes an idea called a fair priority model, which is more nuanced and more complex and suggests that the allocation of vaccines globally should work in 3 steps. First of all, you give any sort of excess vaccine that you are not going to keep for your own country to countries where the objective is to reduce premature death. So it really tackles the rate of infection and the rate of disease. Then once you got that under control, the second layer is reducing serious economic and social deprivation. So the notion is that high infection rate also shuts down the economy, increases poverty, which in turn also has an impact on the capacity to deliver healthcare services and overall human suffering. So then the second layer of prioritization would go based on allowing people to reopen societies, countries to reopen the economy. And finally, the third layer, returning to full functioning or completely achieving herd immunity and reopening society completely. So that's a model that was just put forward. I think the ethical debate surrounding the global justice aspects of vaccine allocation is going to continue. Potentially more models will be suggested. A big challenge will be, even if we have our ethics model all laid out, how are we going to collect the numbers, the measures that tell us how to implement such prioritization? We're talking about global level intricate data that would be needed to support implementing such a nuanced model. So I'm joining Dr. Wilson in saying we're facing a lot of uncertainty, not just on the science and the empirical aspects, but also regarding our best governance and ethical models going forward to get this pandemic under control in the fastest way possible. Thank you.
Thank you, Professor Ravitsky. Okay, so just a reminder to please send your questions in using the chat function at the bottom of your screen. We've already got a couple of questions. So the first one is for Dr. Wilson. Are there historical examples of herd immunity having been reached by infection only without vaccination?
So that's a great question. In many of these outbreaks that have happened in the past where we haven't had a vaccine, they've disappeared, and we're not quite sure how they've disappeared. And a good one is SARS, the first SARS. That came and it went. And some of the presumption that it does occur here is that you do eventually reach that critical threshold where enough individuals are infected, and it does break the transmission. There's also the belief that viruses naturally mutate to becoming more infectious and less pathogenic, and then that sort of creates a vaccine itself for the population. So that is one possibility, and I know that that's been partly behind some of the concepts of the people in Sweden who are pushing for that approach. But generally, the best way I think SARS is one of the few examples of a virus we've eradicated without a vaccine, and typically you do need that vaccine to get rid of it.
Okay, thank you. Professor Ravitsky, on immunity passports, there's still so many unknowns about the virus. You've both highlighted that in your presentations. If we were to go ahead with an immunity passport program, who do you feel is best placed to issue those certificates and on what basis? So again, using those sort of ethical guiding principles.
So obviously, I think it should be the government, definitely not private companies. Based on what? That's a question for Dr. Wilson. Serological tests that have been assessed as accurate enough. But I think what emerges or what is hidden in this question is the ethical issue of equity from another perspective, which is this test will cost money. If we're not covering the cost of the test, we're allowing access to immunity passports to those who can pay out of pocket for the test itself. Add to that the issue of, having access to the information or being, at a certain education level that that these tests exist and that they can get you access to a document that will give you benefits and liberties. So again, the equity issue is inherent here. Unless it's a huge public health campaign to let the population know about this possibility, and the government paying fully for these tests, and even supporting individuals in having physical geographic access to the test, that would be sort of a prerequisite to make this equitable. Beyond that, there are the other issues that I highlighted.
Thank you. For Dr. Wilson, why are we the only country without a vaccine injury compensation program? And do you see that as impacting our potential access to vaccines? Might there be a concern on the part of pharmaceutical companies who could elect to provide vaccines to other countries that have those compensation schemes?
So it's a great question why we don't have a program. It was first put forward in the 1980s by the Canadian Pediatric Society in parallel to what was going on in the US, and we wanted more data for studies. So we got that data, and it supports the fact that vaccines are safe, so this isn't actually going to cost us a lot of money. And I mentioned countries like Nepal have a program. I mean, it's an affordable program. It just kept moving to the bottom of the priority list with all of the other issues we've had to deal with immunization. So it never reached that level at which point it could be pushed forward. I think it's a significant gap. And to your second question, I think it could impede our ability to acquire a vaccine. I think Europe is pushing for a global or continental vaccine injury compensation program to address some of the concerns of vaccine manufacturers. There will be indemnification. AstraZeneca has required that for their vaccine. The question is, will they require immunity? And again, I'm not a lawyer, but if they do require immunity and individuals do get harmed by a vaccine, we will have to have a program in. And to be clear, the vaccine manufacturers are going to be in the driver's seat here. They'll be able to pick and choose which countries get that vaccine. So they can basically dictate the requirements. And they may say, you know, this is what we need if you want to get a vaccine.
Okay. Thank you. So the next question is directed at both Dr. Wilson and Dr. Ravitsky. The New York Times this morning reported that Moderna has shared its blueprint for its coronavirus vaccine trial. How important do you both think industry transparency is, and do you think that this will inspire a wave of ethical disclosures?
I'll jump in with the ethics. I said that perhaps the most critically important element is public trust, and transparency is just inherent in that. So, you know, prior stories in the New York Times exposed the fact that certain clinical trials that had adverse events, those events were hidden. They were shared at first in confidentiality within certain circles, and only then sort of came out. When the public sees that lack of transparency, there will be an issue in establishing the trust in the vaccine when it does get to the point that it's ready. So we can say nothing is more important right now than transparency, because with the hope that we get there, we will need uptake. And for uptake, we need the process to be open and transparent, at the level of maintaining and building public trust, but also at the level of cooperation as much as possible. Obviously, there's billions at stake, and commercial competition is there. But this is the time for everybody to be ethical and share information as much as possible. So both to increase speed and to maintain public trust, transparency before anything else.
Okay. Dr. Wilson?
So, yeah, I actually don't think competition is going to be as big an issue as we may be worried about, because it's just not going to be enough vaccine or vaccine manufacturing capacity. So that's why I think they'd be prepared to share this. We have to make 15 billion doses of this vaccine rapidly. And I think the Indian Institute, which makes the largest vaccine manufacturer in the world, so this could take 3 to 4 years. So all the vaccine manufacturers are going to have to work together to figure out how to scale up manufacturing to make, and we need more than one vaccine. We're going to have 4 or 5 hopefully that get out there, and how can we build enough capacity to provide enough of this vaccine? And it may end up being a seasonal vaccine on top of that. So we're not only going to need 2 doses initially, then you're going to require a vaccine every year. So, I think it's absolutely necessary for cooperation in order to meet that. And then all the vaccine manufacturers will do very well in that, and we want them to do well because we need their products.
Right. Great, thank you. Another question for Dr. Ravitsky. Do you think that intellectual property rights, such as patents, should be restricted in times of pandemics? The question notes that patents on both treatments and vaccines can limit access to drugs at certain times.
Yes. How about an ethicist just answering a question with yes?
Yes.
So I'm not a lawyer, and that is not my field. I think from an ethics perspective, clearly there's strong justification for limiting. Patenting is, especially in pharma, has very clear objectives that at a time like this and under these circumstances are potentially not the winning factor. But I'll actually direct this at you, Vanessa, as the lawyer on the screen. Maybe you can say a few words from a strictly legal perspective on this.
Well, I mean, certainly there has been. I'm not an expert in patent law by any means, but there are scholars who do write, legal scholars who do write in this field about the situations when we do have to put those legal rules on hold or put them aside for the public interest, to ensure the public interest is met. And this may be one of those times, but not my area of legal expertise, but certainly from a legal perspective is something that scholars are discussing. So, Dr. Wilson, do you have any comments on the patent law issue?
Yeah, again, I think it's going to come down, even if you break the patent, you have to be able to make the product. And if you don't have the capacity to make the product, you're going to have to work in cooperation with the vaccine manufacturers, the pharmaceutical industry. So, yeah, I think a cooperative approach will always be better for any country in this case.
Yeah, yeah. Okay, another question for Dr. Wilson. Wondering if you can comment on the idea of the immunity passport, maybe the difference between an immunity passport and a vaccination passport in terms of the feasibility of those two things.
So that's a good question. So we already have immunity passports, so we do have proof of vaccination. So our yellow card is an immunity passport. And in Ontario, it'll gate access to your kids to school. Globally, we have in the Annex 7 requirement in the international health regulations, you need proof of yellow fever vaccine to enter into certain countries where yellow fever is endemic. I think one of the first areas where an immunity passport will be seriously considered is proof of immunization for cross-border travel, and whether this will be added in as a separate vaccine under the international health regulations. And so I think that's where it'll first be tested. I just, for the immunity passport per se, for national immunity, I just don't, the science isn't there, and I don't think it'll be there. So I think that was an interesting discussion. I think it's a discussion worth having. And I think, there were ethical arguments against it, but I think there were also some ethical arguments for it, because let's be clear, in this is the marginal populations that have been affected most negatively. So anything we can do to reduce this illness will help marginal populations disproportionately as well. But I don't think the science is going to get there. And I think we're going to be focusing on immunity passport in the context of immunization. And I think the case will be cross-border travel. Even within Canada, you might find that you need to have proof of immunization to go from one province to another.
Yeah.
We're actually already there in terms of just COVID tests, right? For many countries now, to travel, you have to show up with your negative test results in your hand. So it's just one step further.
Yeah, absolutely. Another question for Dr. Wilson. At the outset of your presentation, you stated that antibodies or immunity to COVID decreases over time, and that's to be expected. Is there a level in general below which one considers that there's no more immunity? Is there a threshold that we measure for?
That is the question that they're looking at right now, trying to figure out what that minimum threshold is, and that's again another challenge in implementing this type of solution. And my sense is, and I'm not an immunologist, but there's increasing focus on the cell-mediated immunity. So even if your antibodies disappear, you may still have immunity, and you may not have the antibody that they're detecting. That you may have cross-reactive antibodies, and then there's this idea that some people have mucosal immunity. that they have immunity in their mucosal linings that allow them to fight off an infection before they even develop an antibody response. What's become apparent to me and just reading around this is there's a lot about immunity we just don't understand, and I'm a little surprised that we still don't understand this. And hopefully through this, there'll be some breakthroughs in scientific knowledge that will help us with treatment of other infectious diseases.
Okay. Another question on immunity. If you develop immunity, how can we be sure that that immunity can protect against the propagation of the virus, for example, being a vector without any symptoms?
We're going to have to use biological models there. So that's generally how it works with other diseases. And we do that. We do antibody testing, for example, if you're working in a healthcare institution and you've got you don't know if you got your measles vaccine or not, they can test for antibody, then we use that as a marker that you are protected. So we can't ever be certain, but we will use the models from previous diseases that it can provide you with some immunity. It's the best I can answer at this point.
Okay, thank you. Okay, so for both Dr. Wilson and Dr. Ravitsky, there's been a lot of discussion about how long it's going to take to develop enough vaccine, enough doses globally. Assuming that we do develop a vaccine that works reasonably well in a short time frame, what can you say about an approximate overall time frame for returning to some sense of normal, to some sense of normalcy? Start with Professor Ravitsky.
The $1 million question.
It is.
Really, there is no answer. I mean, you read in the papers, I think in the scientific literature, people are very careful not to make these predictions. And in the media, you read a year, 2, 3, and now I already read 4. I think the honest answer is we have no idea. But I'd love to hear what Dr. Wilson has to say on this.
Okay.
Yeah, it's a little depressing if you look at what they say. A vaccine may be available in the spring, and then it'll be a while to scale up production to get what we need. It's going to be a combination of approaches. The vaccine alone won't work, I don't believe, because it's just going to take so long. I give you that formula for herd immunity. That reproductive number is 2.2, but other strategies we're implementing will reduce that reproductive number, like masking. So we could reduce that through our other measure to a point whereby we don't need as much vaccine. And every percent, like if we get even 5% vaccinated, that's going to start to substantially reduce the transmission. We have to hope in parallel that there are therapeutic discoveries, because if this becomes a treatable disease, and it's a different disease, we have to hope that this is going to evolve, as most viruses do, into less harmful and more infectious. It is already going to more infectious, but less harmful. So, if a combination of those things happen, we may be able to return to normal without full herd immunity. We may have a less serious condition that has treatments and reduce spread through just naturally acquired immunity, as well as some of the more easily managed measures that we're taking.
Okay, thank you. A question for Professor Ravitsky. You are critical of immunity passports and mentioned the use of better mask policies, improved physical distancing as ways to improve our current situation. Can you speak to any other alternatives to immunity passports, or other ways to roll out something like an immunity passport in a more ethical way?
So I think the main 2 elements in using it without hitting a huge equity ethical wall is, first of all, as I said, not expecting citizens to pay for this out of pocket, not creating a pay barrier to the test itself. And second of all, to limit it to the populations that Dr. Wilson mentioned, who cannot benefit or cannot rely on social distancing or even protective equipment because they're just so exposed. So I think if we do these 2 things, we're mitigating some of the issues. I think if we get to the point that we have a serological test that is very reliable, and for immunity we know how long immunity lasts, the push from policymakers to use immunity passports might emerge again. It was an idea at first without the empirical ability to implement. If the science is there, the political push may become strong to use it. If that happens, even if people like myself and other bioethicists feel that from an equality perspective, it's far from ideal, if there's a strong political push, this may end up happening. But if it does, at least try to implement it on the correct populations and with public funding. That would be my response.
Okay, thank you. Something again for Professor Ravitsky that came up in your earlier comments around ethical concerns. How can we address issues like COVID parties, where people are going to try to become infected so that they can acquire an immunity certificate? That may be a very strong incentive for people, especially, as you've mentioned, those who are unable to get back to the workplace. Could you comment a little bit further on the concerns around acquiring or developing natural immunity?
Honestly, the fear of intentional infection being incentivized is a major force behind the objection to immunity passports. At the end of the day, people who choose to do this, you can't police them not to do it. So we're back to public health campaigns and public education. We have to pass on the message that intentionally getting yourself infected is dangerous for you individually, for your family members. You don't know how your body will respond to the virus. And you're also undermining our public health efforts. So, be ethically responsible, be compassionate, and do the right thing. It's the same message we're sending out about masks. Yes, it's uncomfortable, it's a small burden, but please do the right thing for your society, for the common good. And the same thing we're saying about travel the least possible. Don't socialize more than necessary. It's the same message over and over again. We have to appeal to people's sense of solidarity, sense of integrity, and their choice to be responsible and ethical, because we cannot police all of this. People, excuse me, but people who choose to do stupid things are able to do them.
Okay, a question to you both. And this question relates to the ethics and effectiveness of national lockdowns. Were states correct in imposing these measures as a means to either buy time or limit transmission, given the global numbers that have been increasing, to develop some of these other, whether they're vaccines or other policies to address the pandemic?
Maybe I can start with that. So the general idea in Canada was modeled after the pandemic influenza plan, and the idea is to flatten the curve, but with the goal that you'll have a vaccine available. So you want to reduce the burden on the healthcare system so it doesn't get overwhelmed like we saw in Italy, unfortunately, and then you buy time and you get a vaccine. This is a bit of uncharted territory. We're now doing this with no vaccine really still on the horizon. We're doing this for a year. I mean, I think historically lockdowns haven't really exceeded 2 months. And this is unusual. So I think at the outset, you can easily justify everything we did because we saw what was going on in Italy. We didn't know anything about this. And you could, in that case, using the precautionary principle, argue that more aggressive measures are needed. But as more evidence becomes available, we have to titrate, and as Dr. Ravitsky said, bring in the least restrictive measures. And we are trying that, and then we have to continue to iterate as we get, we're seeing maybe resurgence of cases and figure out the right balance.
So I think two things happened. I totally agree. Two things happened. On one hand, we've learned more about the virus, about effective treatment. So we just feel maybe less threatened by infection because we just understand a little better. And at the second level, we had time to prepare the healthcare systems. We had lack of personal protective equipment at first. We were all petrified of not having enough ventilator. and turning away people whose lives we could save through a ventilator because we just don't have enough. When we shut down in March, people had to wait longer for cancer surgery. For lives are being lost right now because of the delays that were created in the healthcare system. So I think on one hand, understanding better the virus and how to treat it. On the other hand, the preparation of the healthcare system allow us, as Dr. Wilson said, to gradually open up. And we're all aware, especially now in Canada, well, around the world with opening schools in many countries, we're all expecting a second wave. We all know that less restrictive measures may be very temporary, and we may all find ourselves very soon back in various degrees of shutdown. So patience, flexibility, and understanding that our policies respond to evolving evidence. We're not flip-flopping, we're appropriately responding to changing evidence and doing the best and most ethical thing that we can to save lives.